Hello from Axxess. This is Jennifer Gibson. I'm a registered nurse and I'm a certified OASIS and coding specialist. And I'm here with you today to talk about the PreClaim review model, understanding the basics. Let's first talk about some background on PreClaim review and why we're where we are today, looking at having to request a review of our claim before we submit the final claim. Now, the reason that CMS has implemented this PreClaim review is due to extensive evidence of fraud. Now, CMS has been using data to concentrate on Medicare fee-for-service outliers, and the reason that they've done that is that there are several areas identified as having ongoing issues. And in a recent report, as a matter of fact, Medicare has identified 27 hotspots where fraud is just kind of rampant there. However, in the PreClaim review model, these areas that they've zoned in on have ongoing issues, a history of ongoing issues. Many of the states that are in PreClaim review are also in the home health provider moratoria, and there's heavy utilization in those areas that are in the PreClaim review model, and there's also a heavy payment outlier history as well. So all of those reasons together have kind of caused red flags in our areas, and that's why the PreClaim review model has come into effect. Now, to really understand what we're talking about with red flags, let's look at a little bit of improper payment rate data. In 2013, the Medicare improper payment rate was 17.3%. That jumped to 51.4% in 2014, and it's projected to increase to up to 59% in 2015. And the reason that number is not yet finalized is that CMS is still analyzing bills, claim data, and so on, to see what that actual number will be for 2015. And I'm sure they'll let us know when they get that completed to see if that's actually on point or less or more than that projected 59%. Now, the goal of PreClaim review is to assess the PreClaim review model as a means of reducing Medicare fee-for-service home health service payments, while also reducing improper payments and maintaining that beneficiary's quality of care and experience, and or improving their quality of care and experience. Now, during the development stages, PreClaim review was actually called prior authorization. Now we know it's called PreClaim review, and you may hear the terms prior authorization thrown around in reference to this model. However, you should know that PreClaim review and prior authorization are two different types of review. With a prior authorization, the request has to be submitted prior to the services even beginning, and providers then have to wait until they have a decision before they begin providing services to the beneficiary. Because there was some concern about the acuity of the beneficiary's needs and how long that pre-authorization would take, CMS decided to go with the PreClaim review model instead. And in the PreClaim review model, requests are submitted after the initial assessments and intake procedures are completed and services have begun and before a final claim is submitted. So be sure you realize that PreClaim review is different than prior authorization due to the timing of the review and when services begin. PreClaim review is a process to request provisional affirmation of coverage, and in order to do that, we have to submit documentation and other information for review, and the MACs, Medicare Administrative Contractors, will be the entity that reviews our documentation. That documentation will be submitted after services begin, but before that final claim is submitted. And PreClaim review ensures that applicable coverage, payment, and coding rules are met before the final claim is submitted. And that leads us to the point where our environment is no longer a pay-and-chase environment for Medicare fee-for-service money. The model participants are those home health agencies who provide services in the selected states below. Now, the beneficiaries who receive home health care services under the traditional Medicare fee-for-service benefit are those beneficiaries that will be looked at under PreClaim review. The states that are selected are Illinois, Florida, Texas, Michigan, and Massachusetts. And each state will have a different implementation time, except for Michigan and Massachusetts, which will go at the same time. We know Illinois will start on August 1st, 2016. We do not yet know that Florida, Texas, Michigan, and Massachusetts will stay on the proposed timeline because that's subject to change. We know that because the legislation says that Florida is to begin no earlier than October 1st, 2016. Texas is to begin no earlier than December 1st, 2016, and then Michigan and Massachusetts will follow no earlier than January the 1st, 2017. Now, that's important to know because as Illinois rolls out the pre-claim review model in August, we know there are still some wrinkles that will need to be ironed out, some revisions to processes, perhaps through Medicare, through the MACs, and also for our agencies. We know that they have told us from the beginning that they have staffed up the MACs, CMS being they. CMS has given the MACs ample resources to get the staff that they need to be trained and ready for when the submissions begin coming for review. We also have been told that Palmetto will be ready to review requests August 1st, 2016. However, Palmetto was able to begin accepting requests from those Illinois providers on July the 15th, 2016, but they won't begin to review those requests until August 1st. Now, another thing to remember is that we're only talking about episodes beginning on or after August 1st, 2016. Now, when we're talking about bill types for pre-claim review, we're talking about final bills or final claims, or they may also be referred to as end-of-episode bills. And the numbers that you see, the bill types are 327, which is a replacement of a prior claim, or a 329, final claim for home health episode, 32F, 32H, 32I, 32J, 32K, 32M, and 32P, those are all MAC-initiated adjustments, and they are included, as is 32Q, a reopening request. For the pre-claim review model, the following G codes or HCPCS codes are also included. G0151, which is your skilled physical therapy, G0152, which is skilled occupational therapy, G0162 is skilled nurse management and evaluation, and we know that's an RN-only skill, by the way. G0155, clinical social worker. G0164, LPN training. G0299 is RN training. G0300 is LPN direct skill. G0159 is PT maintenance. G0160 is OT maintenance. G0161 is speech language pathology maintenance. G0153 is your skilled speech language pathology. G0163 is RN or LPN observation and assessment. G0156 is your home health aide. And G0157 is physical therapy assistant. And G0158 is your occupational therapy assistant. There is a note here that these codes are subject to change. They may include or exclude others as the study and the model goes on. Let's talk for a few minutes about the pre-claim review model and how RAPs and final bills will be affected by the review. RAPs are not subject to the pre-claim review process. There are no changes at all in the RAP submission process. That RAP can be submitted as usual with no changes in the processing or the payment of a RAP. We also know that when submitting RAPs, providers are given the greater of 120 days after the start of episode or 60 days after the paid date of the RAP to submit the final claim. That means that in the pre-claim review model, agencies can still have RAP privileges suspended while they're in the pre-claim review. What that means is a RAP auto cancellation when that final has not yet been submitted timely will not change under the pre-claim review process. Home health services for less than 60 days will still require a pre-claim review with one exception. Lupus are not subject to the PreClaim review process, and as we know, lupus occur when there are 4 or fewer visits provided in a 60-day episode. So if it's a LUPA, you don't have to worry about PreClaim review at all. However, if you have a 60-day episode and you finish up on day 40 and you end the episode and discharge the patient, you will still need to do the PreClaim review request and go through that same process before you submit your final claim. So which episodes are included? It applies to all traditional fee-for-service 60-day episodes that begin on or after August 1st, 2016. That includes initial episodes with a start date of August 1st, or recertification episodes that begin with the date of August 1st. And as I said, it's only the ones that begin with August 1st. Those episodes that cross over August 1st will not be affected. This is a little bit different than how we implemented I-10 with the PreClaim review. You're actually only worried about those episodes for traditional Medicare home health patients that begin on or after August 1st. Now, should you have a discharge and readmit to the same agency within that same 60-day episode of care, if you have to complete a new admission or a new start of care OASIS is required, then you must also complete a new PreClaim review request and submit that. Now, if, for example, the patient transfers agencies during that 60-day episode of care, the receiving home health agency would also need to submit a PreClaim review request. Some facts about PreClaim review model. Now, when CMS rolled this out, they told us that a PreClaim review request and going through that whole process is voluntary. However, if the agency submits the claim for payment without sending a PreClaim review request, that claim is going to be subject to a prepayment medical review, and if after that review happens, it's approved for payment, the claim will pay, but it's going to pay at a 25% payment reduction. And that payment reduction is not appealable, and it cannot be billed to the beneficiary. The home health agency or the beneficiary can submit the request for PreClaim review and all the applicable services. The request must contain certain elements to be considered complete, and those elements include the beneficiary's information, the certifying physician or practitioner's information, the home health agency's information, and the submitter information. And yes, they actually want the name and the contact information of the person who submits the documentation. Then you'll have to also have the required documentation, as we are going to specify in just a moment, and any other pertinent information that you want to include for review. There are 5 required documentation tasks that must be submitted for each episode's review, and those 5 things include, number 1, the actual FacetoFace Encounter clinical documentation records from the certifying physician that justifies that referral for home health services. So again, they're not looking for a FacetoFace Encounter form that your agency generated and sent to the physician to fill out in like a bullet point or even a narrative way. That can be supplemental information if you so deem that's necessary to go ahead and keep doing that. But CMS and the MACs have told us in their education that they are not looking at face-to-face encounter forms for this certifying information. They want to see the clinical encounter note from either the physician when they go in and see the physician in the clinic, or from the facility if your referral came directly from a facility. The number 2 thing they are looking for is the home health generated records that have been signed, dated, and incorporated into the certifying physician's medical records. And an example of that would be if you receive the face-to-face clinical encounter note and the physician only puts taxing effort for Homebound. We know that that's not enough information to have an affirmative decision in our PreClaim review. So Medicare has told us that the home health agency can supplement that encounter and certification information in that case with documentation from our own records. So we may go out on the start of care assessment and document particularly what it is that makes that patient homebound and address both parts of the criteria for homebound status and confined to the home in our OASIS records. And if we do that and we want to use that as consideration for our pre-claim review, we must then send that information to the physician, have the physician sign and date it, and incorporate that into their own medical records, and then send us a copy of the signed and dated incorporated note, and that way we can use that as supplemental. Number 3 is the certifying physician signed and dated plan of care. So a little bit different in this case in that we have to have the plan of care signed and dated before we can get the pre-claim review to be affirmed. Number 4 point is a signed and dated physician certification of patient eligibility, and CMS and our MACs have told us that indicator number 26 on a 485 plan of care is not adequate to meet the certification requirements. Okay. Number 5 point, medical records that meet each home health requirement for confined to the home. Let's spend a little time really understanding what those 5 required pieces of information that CMS is looking for here. The first one has to do with homebound and confined to the home. Documentation from that medical record must support that the beneficiary is confined to the home at the time of services. Now, Medicare or CMS considers that person to be homebound if 2 parts of criteria are met, and we're going to see what those 2 parts of criteria are. You have criteria 1 and you have criteria 2. For criteria 1, both A and B must be met. So for criteria 1, one of the following has to be true. So either A or B must be true and must be documented easily for the reviewer to find. A is because of illness or injury, the person needs the aid of a supportive device such as crutches, canes, wheelchairs, and walkers, the use of special transportation, or the assistance of another person in order to leave their place of residence. Or the patient has a condition such that leaving his or her home is medically contraindicated. In order for criteria 2 to be met, evidence that shows that there exists a normal inability to leave the home and leaving the home requires a considerable and taxing effort. Both of those must be applicable for criteria 1 to be met. So again, just to remember, the documentation that you send in from the certifying physician and or the records that you have submitted and the physician has signed and dated and made part of his or her records show that the patient meets both items on criteria 1 and one of the items on criteria 2. Let's talk a bit more about the other required documentation facts. We have to make sure that the information we submit shows clearly that the patient was under the care of a physician and that the patient is receiving the home health services under a plan of care that was established and periodically reviewed by a physician, and that patient is in need of skilled services, and CMS defines those skilled services as nursing care on an intermittent basis, or physical therapy or speech-language pathology, or that the patient has a continuing need for occupational therapy. We know that occupational therapy cannot stand alone and cannot initiate care on the start of care. However, for recertification periods, occupational therapy can stand alone at recert. That's the continuing need for OT that it talks about. Another piece of required documentation is that the patient had a face-to-face encounter with a medical provider which occurred no more than 90 days prior to the home health start of care date or within 30 days of the start of home health, and that face-to-face encounter was related to the primary reason the patient requires home health services and was performed by a physician or allowed non-physician practitioner. Now, as we've learned in my ICD-10 coding classes, it's very important that you get that face-to-face encounter documentation from the physician's medical records or the facility's medical records, and that you make sure the primary reason for home care on your OASIS and your bill and your plan of care, they all match, and that they match the reason on the face-to-face encounter as the primary reason for home care. Now, we've talked about all the required documentation points. Let's talk about how you're going to get the information to the MACs for review. For Palmetto, there are 4 different submission methods. You have e-services, electronic submission of medical documentation or ESMD, mail, or fax. Now, e-services is a Palmetto portal, and it's Palmetto's preferred method of submission. And in that portal, when you go in, you'll see that most of the questions have a yes and no, affirmative or non-affirmative answer as you're filling out this PreClaim review request. And then right after you mark yes or no, you have to upload the document that proves the yes. For example, you may see in the portal where it says, is the patient confined to the home? And it will say yes or no, and you'd click yes. And just below that, it would say, please upload the document that pertains to criteria 1. And then you would say, please upload the document that pertains to criteria 2. And so even if it's the same document you're using, you'd have to name that document on a PDF copy, criteria 1, confined to home, and upload it there, and then rename it again, criteria 2, confined to home, and upload it in the next part. So again, that's eServices portal. You will need to view the eServices user manual for more information, including how to get a login credential in order to use the portal. Now, the other types, you have ESMD. You would need to go to CMS's website and look at ESMD for more information. You can also mail the PreClaim review request in, and here's the address for Palmetto GBA on the screen, or you can fax the request in as well. The same 4 ways apply for CGS. The only difference is that the CGS portal is called My CGS, and we will get more information from CGS as the model proceeds to see if they choose to do anything differently than Palmetto will be doing. All right, let's talk about the timelines. Once you've submitted your documentation, the MACs are required to make decisions within a certain period of time. Now, for the initial or the first time you've ever submitted your PreClaim review request for that episode, the MACs are required to make a decision and notify you within 10 business days of receipt of request. So once they get it, they have 10 business days to let you know the decision has been made and what that decision is. The 10-day count excludes federal holidays, and once they have made the decision and notified you, that notification will be sent based on how it is received. So for example, if you choose to fax the request in, you will receive your decision by fax. If you prefer to use the e-portal on their website, you will be notified by e-portal of the decision as well. When you get your decision, you're going to have a notification if the decision is provisionally affirmative or non-affirmed. Either way, you're going to have a notification that contains a unique tracking number, and you'll need to know what that UTN or unique tracking number is. So make sure you hold on to your information, even if it's non-affirmed, and look for that unique tracking number. When you're looking at your review decision, a provisional affirmation decision is a preliminary finding. In other words, it does not guarantee that your final bill will be claimed. It's just saying, according to what we have reviewed thus far, it looks like everything is in order and that this final bill will likely be paid. The future claim submitted to Medicare for the service likely meets Medicare's coverage, coding, and payment requirements, in other words, and that decision applies only to the episode for which the PreClaim review was submitted. So just because you got an affirmation on your initial episode starting August 1st, if you decide to recertify that patient for a second episode, the PreClaim review decision will not apply to the second episode. You'll have to submit a review request for that one as well. Finally, your decision notification will include that unique tracking number or UTN. It will also tell you which HCPCS were affirmed and a detailed explanation if you have any requirements that were not met. All right, so what if you get a provisional affirmation decision? It is not transferable again. It does not follow the beneficiary. And if the beneficiary transfers to another home health agency, even though you have an affirmed 60-day episode of care, that receiving agency would also have to submit their own home health pre-claim review request. There are two other types of MAC review decisions that you might get notification of. One is a non-affirmation decision, and that's rendered when the documentation that you submit does not meet one or more of Medicare's requirements for payment. Now, that non-affirmation notification will include the non-affirmed unique tracking number, which HCPCS were non-affirmed, and a detailed explanation of which requirements have not been met to affirm the HCPCS codes. Now, if you should get an incomplete, that means that your pre-claim request had some information that was missing. So your notification in that case would tell you particularly what information was missing, and you would not get a UTN in that case. For non-affirmed decisions, a pre-claim request can be resubmitted. So let's talk about resubmissions for a bit. So the submission process is the same as for initial request. So if this is your second or third or fourth attempt at getting an affirmation decision, you would select resubmission on your request, and then you would provide the unique tracking number of the most recent non-affirmation decision letter that you received. There is no limit to the number of times the pre-claim review can be resubmitted. Now, the only thing that's going to be different than having to select resubmission on your subsequent requests is that the timeline for the MACs to turn that around for you is going to be different. When you do a resubmission, the MACs have an additional 20 business days to conduct that medical review, make the decision, and notify the requester of the decisions. And again, the count begins for them on the date that they received the pre-claim review request. Notification will be sent to the submitter that provides a provisional affirmative or a non-affirmation decision. Notification will also be sent to the beneficiary for each request that's received. That's important to know because they'll get an explanation of benefits that's similar to what they get when they go in and see the physician at the clinic, or maybe they've been to the hospital and they get an explanation of benefits. They will likely get an EOB that notifies them that your agency has submitted a request to review and got an affirmative decision on providing care for them during that episode. And these little seniors will probably not know what that means, so you may have to notify them what that's all about. All right, so now we've talked about how to submit the documentation, how you're notified, and what the different types of notifications are. So now that we have an affirmative decision, let's talk about the billing of our final claims. Now, the normal data submitted on the claim is still required. We're still talking about types of bills, 329 and the others that we listed earlier. We have on the slide here some specific information for billing. It tells us to enter the 14-byte UTN provided in the PCR notification and how to put it on an electronic claim and so on and so forth. The only thing that you really need to know, especially if you're an Axxess user, is that what we're looking for here is that your unique tracking number will be in position 19 through 32 of the Loop 2300 REF02. And it's going to follow right after your OASIS assessment data, which is your OASIS unique tracking number that comes in position 1 through 18. So basically, whether you're looking at an electronic generated claim string or you're looking at this on your UB04, what you're going to see in Locator 63 will be your unique OASIS ID, and that will take up the first position 1 through 18, and then right after that, starting in position 19, you'll see that unique tracking number amended to the end. So you're going to have a 32-character string of data, basically, that spot. CMS has confirmed, by the way, that Locator 63 on the UB04 can accept all 32 characters, so we should be good to go there. Let's talk about some final claims facts next. The claims are subject to all processing edits as before. If requirements are met and provisionally affirmative decision was issued, then payment is going to be made on that claim. However, if a non-affirmed decision is made, Medicare is going to deny payment on those claims. And the reason behind that, of course, is that the patient did not meet the criteria for receiving the Medicare home health benefit to begin with. Now, a denied claim based on a non-affirmation decision will constitute an initial payment decision, and the standard claims appeal process will apply. Now, if you choose not to submit a pre-claim review request, the following things will happen. The claim will automatically be held for prepayment review, which means they're going to review everything before they pay you at all. You will also receive an ADR, additional documentation request. All of those same prepayment review regulations will apply. And upon review, if the reviewer determines that the Medicare criteria are met, that claim will pay minus the 25% reduction. If the reviewer determines that all Medicare criteria are not met, however, that claim will be denied, and once you get that denial, you may appeal the decision. Remember, the 25% payment reduction is not transferable to the beneficiary, and that 25% payment reduction is also not subject to appeal. One thing to note, however, is that payment reduction will not be applied during the first 3 months of the demonstration in each state. That gives you time to hone down your processes, get things in place, and make sure that the process and the flow works well. And it also gives Medicare time to iron out any wrinkles as they implement states. So remember that payment reduction will not be applied the first 3 months. Appeals process. Remember, the standard appeals process applies to the final claims. There will be no appeal process if you have a non-affirmation decision. The only way you can get the appeal rights is if your final claim is submitted with a non-affirmed UTN, then you'll get a denial on the claim, and then that denial will give you the ability to appeal. However, if the agency goes through pre-claim review process and a final claim is submitted without the UTN, that claim will RTP. In other words, if you forget to put it on your final claim, then that's going to return to provider because CMS has on record, or your MAC has on record, that you were issued a unique tracking number and you didn't include it on your claim. And for that reason, it's going to return to the provider so you can add it to your claim as well. Let's talk about how this might impact your resources. Needless to say, your pre-claim review process is going to require additional manpower. While there are no new documentation requirements, the timeline on which you have to turn around the signatures and also get that documentation in will probably have to be rushed a bit. Documentation is going to have to be reviewed and submitted more quickly. So if you outsource coding or you outsource any kind of QA services, that will need to be looked at. And you're also going to need to look at all the available resources that you have and see how to address these additional documentation needs. So let's talk about those processes just a bit. So some of the processes you're going to want to focus on for review include referral intake, your eligibility check for insurance, your clinician documentation, your coding and OASIS review, the plan of care completion and review, your community liaison, your orders management, and then of course the billing timelines are important as well. Let's talk for a moment about referral intake. Of course, we know it's important to obtain as much information as possible from the referral source. There's no standard documentation list, but some suggestions include things such as discharge summaries, progress notes, the problem list and diagnoses list, your medication list. We know that information should be reviewed on receipt, and you have to make decisions as to whether or not the criteria have been met for Medicare fee-for-service payment for home health. And in order to do that, you need to ensure that the eligibility criteria, as we talked about, is well documented, and that includes that the beneficiary is confined to the home, the beneficiary needs skilled services, the beneficiary is under the care of a physician, and is receiving services under a plan of care established and periodically reviewed by a physician, that the physician has certified patient eligibility, and that the patient had a face-to-face encounter with that physician within the time frame that we talked about earlier. Let's talk about insurance eligibility for a moment. You need to make sure that you're checking the patient's insurance eligibility, because this PreClaim review only applies to traditional Medicare fee-for-service beneficiaries. So if they switch to an HMO and you're looking at that info and you miss it, you may be going through a lot of burdensome paperwork for no reason. You also need to know if Medicare is going to be a secondary insurance payer at all, because you still have to meet all the Medicare criteria in order to bill Medicare, even if it's a secondary payer situation. Let's also talk about processes regarding clinical documentation. Having that documentation completed timely is going to be a big factor, because you're wanting to get that info turned around and sent out and signed and all of that, so that you can go ahead and get your PreClaim review affirmative decision so that you can bill that final timely. Now, you must make sure you allow time to review the documentation before you send it in. Make sure all the G codes are included on your PreClaim review request. For example, if you're going to be providing nursing and PT, make sure you put the G codes for both the RN and the LVN, or the PT and the PTA, because if you only get one G code covered and then you send out the LVN, for example, and you only got RN covered and affirmed, then you're going to be up the creek when it comes time to bill the final. Make sure also you coordinate with the physician to finalize the orders and amend the plan of care. For your community liaison processes, you want to make sure that you've really evaluated what your liaison does. That liaison could be key in obtaining the documentation from the referral source to begin with. They may also be able to help you with obtaining signatures on plans of care and such timely, and they may even facilitate the education of your referral sources. For orders management, of course, you're going to need to look at frequent follow-up on outstanding orders and documents. Make sure that the facility and physician medical records used are also signed and dated. An electronic signature is acceptable, but you must have a signature on that facility record. Even if it's a discharge summary, you may get the preliminary copy. You'll have to go back and get a copy that is signed and dated as well. The orders for all disciplines must be signed and dated, and know that unsigned orders that are submitted will not be considered and may lead to a non-affirmative review decision. For billing, remember RAP processes don't change with PreClaim review, so the RAP payment money can be recouped, and it will be if the final is not billed within 120 days of the start of care date or 60 days of the RAP billing date, whichever is greater. So you're really going to need to monitor those timelines closely and keep up, for timely filing reasons, those dates that you sent the information in for RAP, so that your end of episode or final claim is billed timely as well. We also know that a high percentage of recoupment in your RAPs could result in suspension of RAP privileges. For final claims, again, the timelines have to be closely monitored. Make sure you coordinate with your PreClaim review status. That's going to be real important to make sure you don't have RTPs because you left off the unique tracking number and such. Remember, if the final is sent without the UTN, it's going to reject if you never got a UTN to begin with, or it'll return to provider or RTP if you got a UTN and you forgot to add it on the claim. If you get a non-affirmative or you don't go and put the UTN on your claim, you're going to be subject to a prepayment ADR if no review was ever requested. And once it pays, if it's approved after ADR, you're going to get 25% less payment. In closing, just some final thoughts to think about. Remember, the PreClaim review model will continue for 3 years, and the PreClaim review payment reduction does not apply for the first 3 months of inception in each state. And we highly advise agencies to use the first 3 months to really streamline those processes. Remember, together we can succeed in the pre-claim review process and the model. As I'm often heard saying, there's a lot to think about, but there's nothing to worry about, especially if you've been following your processes all along. If you realize from this education that there are some things that perhaps you weren't doing properly, you certainly still have time to revamp those processes and monitor those through your QAPI program and make sure that you're ready to go when pre-claim review begins for your state. One last thing to think about as we talked about freeing up manpower and freeing up your resources, don't forget that Axxess does provide billing services. And with that additional manpower, just taking away the burden of billing and freeing up that manpower will allow you to have perhaps less staff being hired to help you with PCR. And we only charge a small fee for billing services too. Okay? So thank you again for joining us here at Axxess and trusting us with your educational needs. I hope that you learned something today that will be useful to you. And should you have any further questions, you're welcome to shoot me an email or give me a phone call. I'm more than happy to help you with questions that you might have as well. Okay, this is Jennifer Gibson again with Axxess, and thank you again for joining us. Have a wonderful day, and thank you for all you do to make sure that patients receive the care that they want and need in their home.
Thank you for joining our webinar today. We know that your time is valuable and are happy you chose to spend it with Axxess. At Axxess, we're proud to offer a variety of training resources to keep you in the know on industry news and updates. You can register for additional trainings and watch on-demand training videos through our software or at Axxess.com, where you can also find tutorials, online manuals, and answers to frequently asked questions. We're always just a call or click away. Feel free to call us at 866-795-5990 or email us at support@axxess.com. All of our expert client experience representatives have a home healthcare background. They've been in your shoes and know the industry inside and out. Join the conversation and connect with us on our social channels. We'll keep you up to date with what's going on in the industry and share resources to help you grow your business and improve your patient outcomes. Thank you again for your time today and for choosing Axxess, your provider of complete home healthcare services, software, and solutions.